So good evening, ladies and gentlemen. So I'm going to discuss about the insulin. So why I have put this insulin, I consider this as the king of all the anti-diabetic medications, and all the other anti-diabetic medications are like queens. And so we'll look at metformin actually reduce the resistance of the king and makes the king smoother, and pioglitazone a similar way, and sulfonylurea stimulate the king and probably make the king more aggressive. The new queen SGLT2 inhibitors does not stimulate the king or does not reduce the resistance of the king, but take over the burden of the king, so king has less work to do. The incretin queens stimulate the king, but not only that, the incretin queen also manipulate the ministers also, like glucagon. So moving into the case, a 58 years old female was referred to improve glycemic control, type 2 diabetes for 12 years, BMI 27, and she is on 3 oral hypoglycemic with maximum dose. She has satisfactory dietary pattern, exercise regime, and good drug compliance. So there is no improvement with regard to diet and exercise. Values HbA1c 11.7, fasting ppbs all are high. So how do you manage this patient? Few things we need to understand regarding the natural history of type 2 diabetes. So you can see the type 2 diabetes has two major pathologies. One is insulin resistance, and other one is gradual failure of beta cell function. So you can see here insulin resistance increases even before the diagnosis. So increase, and then after the diagnosis it somewhat becomes a plateau. And if you look at the beta cell function, again beta cell function also deteriorate even before the diagnosis, and then it gradually deteriorated, and insulin secretion also gradually goes down. So our patient type 2 diabetes for about 12 years, lie in between 10 to 15 years. So if you think beta cell function is almost negligible or almost close to zero. So if you understand the natural history, the answer would be insulin in this patient. Another way to look at would be the efficacy of hypoglycemic drugs. So you can see HbA1c reduction, the most effective drug would be insulin, which can reduce HbA1c by about 1.5 to 3.5. So you could remember the patient HbA1c was 11.7. So if you want to make it around 7, you need to have a very effective drug, and in that way also insulin would be the answer. So then how about the guidelines? Whether the guidelines agree with this approach? So our patient at the level of triple therapy. So when it comes to 4 drugs, most guidelines agree. This is ADA guideline. It has to be a combination injectable therapy, either insulin in the form of basal insulin or mealtime insulin. So in 3 ways, this patient needs insulin. If you look at the natural history, then if you look at the efficacy of drugs, or if you look at the guidelines also. So you have decided to start insulin, and which regime? There are mainly 3 regimes. BIDS regime, which you call bedtime insulin and daytime sulfonylurea. Basically here you continue the oral drugs and give a basal insulin at bedtime to cover fasting hyperglycemia. Then you have, you can say, prandial 3 injections or basal bolus insulin regime, which I think is the most physiological way. You give the basal to cover fasting hyperglycemia, and then give 3 boluses to cover breakfast, lunch, and dinner. And there's another insulin regime which is still in use in our country and also in other countries also, pre-mixed insulin twice a day regime. So this you give an injection before breakfast and another one before dinner. So this pre-mixed insulin contain regular insulin or short-acting analog with a mixture of intermediate acting. And so you can easily cover breakfast and dinner, but we'll see what's the problem with that regime. So the choice of insulin regime depends on patient's glycemic burden pattern, whether the patient has predominant fasting, prandial, or might have both, and it depends on the diet and lifestyle also. Above all, it's important to understand the patient's preference, because as practicing clinicians, we know how difficult to start insulin in a patient. So it's always understand the patient's background also when you consider an insulin regime. So you have two strategies here. You can control prandial sugar or you can control fasting sugar. So this is HEART 2D trial. So in this trial, the patients who had MI were allocated either prandial strategy or a basal strategy and followed up for about 3 years, and to see whether there is any high cardiovascular event in whichever the group. What was the conclusion? No difference in risk of future cardiovascular event rates. And if you look at the HbA1c, again, HbA1c reductions are similar and not statistically significant. So prandial you need to give 3 injections, basal you need to give 1 injection, and most of the patients would be happy with 1 injection, and it's cardiovascular wise safe. So decided on basal insulin. There are 2 types, isophane insulin, also called NPH insulin, and also long-acting insulin analogs are there, like glargine, detimine, and degludec. So you can see the profile of each insulin. NPH, it's isophane. Action lasts for about 6 to 18 hours, and there's a peak around 6 to 8 hours. And detimine, 20 to 24 hours, and there's a marginal peak. If you look at the insulin glargine, lasts for 24 hours and there's no peak. Although not included in this graph, degludec lasts longer for about 42 hours and there's no peak. So if you think about the profile wise, which one is the better one? Either insulin glargine or insulin degludec. So always we have to prove which is the better one. So choice of basal insulin. This is a meta-analysis. They have compared long-acting insulin analogs versus NPH insulin to see mainly with regard to efficacy of HbA1c reduction and the risk of hypoglycemia. The conclusion, long-acting insulin analogs in type 2 diabetic patient does not seem to provide better glycemic control in comparison with NPH insulin. So if you think about the HbA1c reduction, both are the same, analogs and isophane insulin. However, as you can remember the profile, since there is no peak, the analogs has reduced risk of nocturnal and symptomatic hypoglycemia. So if you think about the hypoglycemic risks, analogs are better option. However, 2 disadvantages. One is the price of the analogs. The second one would be a bit of weight gain associated with analogs when compared with isophane insulin. So when you start insulin, you have to see the cardiovascular safety. So this is origin trial, compared the insulin glargine with standard therapy, followed up for 6 years. And cardiovascular event rate, if you see the hazard ratio crossing the midline, so not statistically significant. And also, so cardiovascular safety proven. And then always this argument, because the insulin glargine has some increased affinity for IGF-1 receptors, so there's a possible risk of increased neoplasms argument, but after 6 years, the cancer occurrence is similar in both groups, so results are reassuring. So you decided on starting basal insulin. So how do you start basal insulin? So you would start with bedtime intermediate acting insulin or a long acting analog. So initial one would be around 10 units or 0.2 units per kg, and you check fasting blood sugars every 3rd day and adjust the dose accordingly to achieve the desired target. Say for example, if sugar is 170, then you increase the dose by about 2 units and then repeat the same cycle over and over again to achieve desired fasting blood sugar. So patient was started on basal insulin and came back to you with HbA1c of 8.7 in 3 months time. So what's your target? Around 7. So what will be the next step? So you think, you see whether fasting is fine. Yeah. If that is the case, then you have to think where the problem lies. So you have to do blood glucose monitoring at home. So you can see if it is, say, you check post breakfast or pre-lunch to see whether the problem with breakfast, and then to see the problem with lunch, you check post lunch or pre-dinner, and to check the dinner, you can check sugars at post dinner, and which is a very common finding in our setup and in our society, because we tend to take a high carbohydrate meal at lunch. Most of the time it's the post lunch hyperglycemia is the problem. So if that is the case, the option would be adding a rapid acting or short acting insulin with lunch or before the lunch, and then you adjust the dose accordingly and check the HbA1c in 3 months, and if they achieved HbA1c target, fine, you continue, and if there's a problem, and you again go for this cycle again and see the problem. So all are, it seems very simple, but you know, as practicing clinicians, it's not so simple, because always there's a patient. So patient might not adhere to the diet, might not adhere to the regular injections, and sometimes it will be difficult to get the HbA1c. So motivation also very crucial. So there's another insulin regime, pre-mixed insulin twice a day. So if you can see, complexity wise, 2 injections, probably moderate complexity. However, the flexibility is not so good with this regime. We'll see why. So pre-mixed insulin twice a day, and mainly, as I mentioned, it doesn't cover post-lunch glucose excursion. So you can see breakfast insulin injection contain regular insulin and an intermediate acting insulin. So breakfast can be covered, and dinner, that's fine. However, how about the lunch? So how do you control lunch here? You have only insulin, intermediate acting insulin, and to cover the major carbohydrate content, if you are trying to do this, it will be very difficult. So research wise, is it true? So this trial, 3-year efficacy of complex insulin regimes in type 2 diabetes. So they have allocated into 3 groups. One group received biphasic insulin, which I mentioned earlier, and other group prandial, and third group basal. The conclusion and findings, you can see the percentage of patients with HbA1c less than 7 in biphasic group, it's only 49%. Prandial group 67%, basal group 63%. So you can see statistically prandial and basal insulin is better than biphasic insulin. So physiology wise it's not sound, and research wise also, findings wise also, it's not sound. So what is the ideal insulin regime? This is called a basal bolus insulin regime or concept. So you give a basal insulin to cover fasting hyperglycemia, and 3 regular insulin to cover breakfast, lunch and dinner. So if you practice this regime with proper diet and proper adherence into the protocol, so most of the patients will achieve very good glycemic control, but downside would be the number of injections, 4 injections per day. So in that you have to give prandial insulin. There are 2 types, short acting regular insulin or rapid acting insulin analogs like aspart, lispro and glulisine. So you can see the profile again. So aspart and analogs, action starts in about 5 to 15 minutes, whereas regular insulin starts in about 30 minutes. And regular insulin action lasts for about 6 hours, whereas analogs only about 4 hours. So if you think about the postprandial glucose excursion, the better option would be analogs than the regular, and other advantages can be given immediately before the meal. So with regard to research, is it true? These are the 2 research, actually one is a meta-analysis and other one is a Cochrane database review. In both ones, if you look at the data, there's no increased risk of hypoglycemia with regular insulin also. And in one actually Cochrane database review, HbA1c reduction also not so significant by comparing both groups, whereas in other meta-analysis, HbA1c reduction is slightly better with analogs. However, if you look at the profile, it seems analogs are better than regular insulin. So, the next question is, always this question arises, can we combine sulfonylurea with insulin? So, first is understand the basic principle. Now, because of insulin deficiency, you are giving exogenous insulin. So, when you are giving exogenous insulin, and if you give sulfonylurea, that will increase the endogenous insulin levels if beta cell function is there. So, it looks not very rational because you are giving two drugs with same mechanism. And other thing is that when you start on insulin, the patients also would like to have reduced their pill burden. So, patient will be happy if you are starting, they should have some profit of starting insulin. So, if you are going to continue the same drugs and adding insulin, then patient will feel a little bit distressed regarding there is no much difference. So, this trial way back in 1999 from Finland. So, they have checked combinations of insulin with sulfonylurea, insulin with metformin, insulin with sulfonylurea plus metformin, and insulin alone. If you think about the weight gain wise, the least weight gain achieved in insulin and metformin group, whereas insulin and sulfonylurea group slightly significant weight gain. If you think about the HbA1c reduction, the best is with insulin plus metformin, whereas insulin plus sulfonylurea, the HbA1c reduction is not so great. So, if you think about this data, it seems of course, with BEATS regime, that means basal insulin only with one injection, you continue the oral hypoglycemic, but once you are changing into complex regimes like basal bolus or basal plus prandial, then it's always wise, and it's always the common practice would be move away from sulfonylureas to reduce pill burden and start on complex insulin regimes. So, last question, how about insulin as the first line therapy in type 2 diabetic patient? This is a Chinese study. So, newly diagnosed type 2 diabetic patients were randomly allocated to either standard group of oral metformin and glycoside versus insulin, multiple daily injections or insulin pump. So, the findings were, so what they have done, they have started on these two groups, and normal glycemia achieved quicker in insulin treated groups in about 4 to 6 days time, whereas in oral hypoglycemic group, patients were achieved normal glycemia in about 9 days time. So, once they achieve normal glycemia, the treatment continued for another 2 weeks, and treatment stops and advised on dietary and lifestyle modification. And after 1 year, they checked the remission rates of these patients, and the finding was that patients who were treated with insulin, the remission rate was around 51%. So, they were in remission from diabetes, whereas in oral hypoglycemic group, remission rate was around 26%. So, there are significant difference in remission rates with regard to this strategy. However, the major drawback of this strategy would be starting insulin at the beginning. So, making the diagnosis and telling all these things and plus insulin 4 times per day regime, it will be not very practical. Because of that reason, not in common practice. However, my basic message here would be, if you get a patient with significantly high HbA1c, say around 11, 12, with significant catabolic features, small catabolic features and osmotic symptoms, it's always this option is a very good option starting insulin probably with metformin at the beginning and then gradually move away into other oral drugs also. This is type 2 diabetes at the beginning. So with that, thank you very much for the patient listening, and I want to highlight few facts about insulin in the limited space of time, and a tribute to Banting and Best, who discovered insulin, which is at the moment the king of all the anti-diabetic therapies.